Okay, I think we're going to get started with Alagille Care Part 2. So anybody who was not here this morning? Any newcomers to the room? No? Okay, great. Well, so again, we have a very similar approach. We have a panel of experts. We'll have some topics and a lot of discussion. Hopefully we'll answer questions that you have. So I'd like to, again, invite the panel to join me back up on stage. David Piccoli and Ruben Quiros from this morning's session, and then we have a couple of new panelists, Roberta Smith and Dr. Jeff Feinstein. It's all you, Roberta. Yeah, no, they're coming. Thanks, Ruben. And Cindy, I know, is getting David. While David's joining us, let me just introduce Jeff and Roberta, and they can give you a few words about their history with this disease. So Dr. Jeff Feinstein is a professor of pediatrics and bioengineering at Stanford University. He's a pediatric cardiologist at Lucile Packard Children's Hospital and the director of the Pediatric Pulmonary Hypertension Program and the director of the Center for Pulmonary Vascular Disease at Stanford. So Jeff, you want to give a few words about how your world intersects with Alagille syndrome?
Sure. You left out the last two sentences, which explains how my world interacts.
But I figured they would
that
come
was
better.
well
They
done.
would come better for you, from you.
No, I understand. So I'm lucky enough to deal with all things pulmonary vascular in my world. So it started out as just dealing with the patients who had high blood pressure in their lungs for one reason or another, and it over time has morphed into being fortunate enough to work with the kids who have what I call structural abnormalities with their lungs. So the most common structural abnormalities that I'm sure most of you are familiar with are the pulmonary artery stenoses, the peripheral pulmonary artery stenoses. As an engineer, I find the stenoses particularly interesting in that a lot of them have effects on where the blood decides to go. And so working from an engineering mind, trying to optimize how we can get the blood flow to go to the proper places in the most efficient fashion becomes fascinating to me. I'm lucky enough to have a bunch of colleagues at Stanford who do a lot of work in Alagille, both in the transplant world and the GI world, in addition to having some incredibly talented surgeons both in the cardiac world and in the neurosurgical world, in the Moya world. So being in the right place at the right time with a combination of interests that happens to overlap particularly nicely in the Alagille world has made this a particular passion for me.
Excellent, thank you. And we're also joined by Roberta Smith to give that Alagille warrior, been there, done that perspective. Roberta is the mother of 12-year-old twins, Claudia and Chloe is her Alagille warrior. She's a nuclear medicine technologist by training, and she also works at ItWorks distributor, and she is on the board, as you can tell by her uniform. So, Roberta.
I specialize in parenting. Maybe not so professional, but I do have the nuclear medicine side of it, so I do deal with, the HIDA scans, which many of our Alagille patients have. And, of course, I have the twins. I have one with Alagille and one without. And so I've been on the board for 3, maybe 4 years, but I've also been writing a column in the newsletter since 2005 called Roberta's Ramblings. So that's my aspect.
Excellent. Well, we enjoy hearing some of those ramblings this morning. So I hope you all enjoyed a break, had some time to get some coffee, maybe some fresh air, and we're ready for the next session. This morning, just to remind everybody, we covered eating and digestion, color and skin. And now we're going to talk about movement and energy and the head and the brain. So let me see where we're at. But isn't it involved in all of that? Boom, boom. Okay. So hopefully you had at least some of your questions addressed this morning. If you did not, I would encourage you to come one-on-one to any of the panel members, any of the board members. If you have a question, you don't know who to ask it to, come to the board members and they will help direct you. And I think the most important thing for you, having traveled to San Diego, which is my home and I absolutely love it, so welcome, is that you get your questions answered. Or if you don't get them answered, that we find out who can answer them for you. So I encourage you to be proactive about getting your questions addressed. Okay, so movement and energy. And as David talked about this morning, maybe there are certain things that children with Alagille syndrome at various stages of their condition should or shouldn't be doing. And I think that challenges for a person with Alagille syndrome may have a lot to do with movement and energy, including bone fractures and breaks, bowed legs and rickets that we heard about associated with vitamin deficiencies, balance problems, behavior and ADHD, oxygen deficiencies, the list goes on, fatigue and tiredness, and how do we think about sports and physical activity. And again, as always, you may not have had to deal with these challenges yet. You may be worried about how you will address these challenges in the future, and you may not have to deal with them at all, but I think that that's part of the discussion for today. So we're going to do what probably feels like a little bit of a step backwards, and maybe we can not spend too much time on this because we really covered it this morning, but vitamin D. So we heard this morning that it's associated with growth failure and poor nutrition and bone problems. We heard about strategies to maintain, supplement, monitor vitamin deficiencies. I think that really when it comes to the bone issues, vitamin D really is the key culprit. I guess I would just ask the panel, anything to embellish upon from this morning's discussion? Should we kind of, unless maybe anybody in the audience has a specific vitamin D question. Because I think there's lots of other things that we can get on to discuss. Okay.
I was going to say just one thing. I was told once by a vitamin D researcher that there's a vitamin D receptor on every cell in the body, and it does a tremendous number of things, and we're now starting to look at it in terms of immune function and other things. So to go back to the question from before, checking levels, definitely keep checking the vitamin D, the 25-hydroxy vitamin D level, and really push it. I think that's one of the most important things you can do. It's more than bones, but it's critical for bones. So,
thanks, David. Okay, bones, breaks, bow legs. I guess it's the 3 Bs. If your child, your Alagille warrior, does not get enough calcium, phosphorus, or vitamin D, they may develop rickets. And some signs of rickets include bow legs, softness in an infant's skull, abnormal curving of the spine, bone pain or tenderness, and muscle cramps, decreased muscle tone. And Alagille can also disturb normal bone function and cause a person to be shorter than normal, so short stature is also associated with this condition. Depending on the severity of the disease, bone fractures and breaks can be more common in children, especially of the long bones in the arms, legs, fingers, feet, collarbone. I'm not sure what's left when you get through all that. It could be a problem. Any comment from the panel about breakages? How often do you see fractures, and are they any more complicated to deal with and treat in patients with Alagille syndrome?
we could do a poll. How many of you have a child who's had a fracture? Yeah. So when we did the original survey through the Alliance with Cindy, we were struck by how many people had kids who broke the long bones in the legs, and particularly the big one. And so we think that that's some combination of vitamin D and other things, but the rate of fracture of like the femur is massively higher than other pediatric liver diseases or other kids. I mean, a lot of kids break their wrists and so on. And we think that part of that is the structure of the bone, and we know that jagged is in the cells that remodel bones, and that's why they have things like butterfly vertebrae and so on. So there's something sort of unique about the femur the chest cavity, as well as the spine, as well as the shape of the hands, and so on. And so some of these bones seem to have their own unique susceptibility, separate from the vitamin D question. There are people who say, my daughter just like stepped into the tub and the bone broke, and then she fell. Not that she fell and broke her leg. And but a 2-year-old falling in the tub should never break their leg. They're not that heavy. They're not that sort of thing. So.
Okay. Thank.
I just want to add that we have better understanding now on the vitamin D deficiency, vitamin D roles, and I will say the awareness about bone health, and not only in Alagille, but in liver disease has increased significantly, and I think the understanding of vitamin D and how to look at it and how your relation to the equator is, because the sun play a role as well, gave us a little bit of a better understanding and how to prevent some of these things. But I think even though this may not be just related to vitamin D absorption, vitamin D metabolism, as far as the bone health, because of what David mentioned, but I think you have to optimize that, and that's something that I think through many years has been doing this. We overlook at the very beginning, and now I think we're getting more aggressive about.
Do you see a difference pre and post transplant?
Yes, yeah, there is a different pre or post transplant when the bone health. I think I don't see it as much, but at the very beginning of my career, one kid got transplanted just because he kept on breaking their bones, and it was an Alagille syndrome. Sorry, it was an Alagille syndrome kid, and that was the indication for it. And I haven't seen that. I mean, I'm talking about in the late 90s when I saw this. And I think there's a difference. That kid did much better. Still, you have to supplement him with vitamin D at the beginning just to have his bones rebuilt. But I mean, it resolved the problem that he had before. Then definitely you take away that factor of the malabsorption because of severe liver disease. Usually it gets better. But you still have to keep.
Looks like Roberta has a comment.
When Chloe was just over a year old, she was delayed in her crawling, and I had been watching her scoot across the floor rather than crawl. And I would recognize little whimpers when she'd put any pressure on her arm. And it did come to a point where I took her in and I questioned, is something going on here, with her arms or bones, whatever it might be. Knowledge is power, and when you aren't in the, when you're not in the position yet to come across some of these things, knowing that these things are possible, it helps you to watch. And so paying attention to how your child's crawling, how they're walking, are they limping? Are they limping for long periods of time? It's important as a parent to not doubt yourself and go in and ask these questions, to have them checked. She did have a green stick break in her radius and was casted at, a year and a half old. And then again in 4th grade, had a slip and fall on the playground and broke her femur in half, where she did have to have surgery for that. So aside from, the clinical aspect of it, as a parent, we go through a lot of doubt. And are we sure of what we're seeing? Questioning that. And so you have to be the child's best advocate and certainly go in and ask these questions.
Mm-hmm. Thank you. So we'll also get into some discussion about balance. And has just a poll of the audience, when your child was younger or even now, have you experienced balance issues, instability issues? Raise your hand. Okay, so quite a number. And I think building on the bone issue that we just heard about, I'm sure balance issues can compound that bone breakage issue. There are lots of things that can affect the balance, of course. Certain medications, ear infections, head injury, blood pressure, arthritis, even eye muscle strength. So, it may not necessarily always be associated with Alagille, but I think it's worth understanding and trying to explore if you see that in your child. ADHD or itching. It was interesting when we were doing our research through Lumina. We heard a couple of comments, particularly from the parents of older children. that went along the lines of something like, they don't itch when they're playing their video games, but when it comes to doing homework, they get really itchy. So I think that you would, it's natural to question what's driving some of your child's behaviors and responses. We talked a lot about itching earlier. We talked about new treatments for itching, so we're not going to revisit that, but I think we can talk about concentration, and we'll talk about just the specifics of your child and whether they need to move around more, whether there's an increased diagnosis of ADHD as a brain disorder amongst Alagille children, which obviously leads to them needing different set of support and interventions. Anybody want to comment on ADHD or anything that you see in your practice specific to children with Alagille syndrome?
Obviously a big issue, and so the consortium has started to really look formally at neurocognitive outcomes in pediatric liver disease and Alagille syndrome. I think one of the things to say is that, and people who are parents of any infant probably remember this at least during infancy, when you don't sleep well, all of the daytime behaviors are jeopardized, and sleep is just so critical, and so it's very hard to tell someone who has interrupted sleep or poor sleep with many of the ADHD sort of daytime issues, school function issues, and so on. So it's an area that's now receiving appropriate increased focus, but it can be very hard to tell apart. So one thing is, and I think there'll be a session on it later today, to get the evaluation and the advocacy at the school system so that you make sure that you have the supports in place for your child so that they have the ability to keep up and to be supported through those early school age years where this seems to be the worst.
Okay. So a domino effect that we're seeing here with balance and breakages, perhaps, with itching and sleep and behavior. And obviously, oops, went a little bit too far. We're missing a slide. Okay, there's a slide in here that talks about fatigue and tiredness. If you're not sleeping well, clearly you're going to be more fatigued, have more tiredness, which I think just continues to compound these issues. So
I would say, sorry,
that's good.
and how many parents think that when their child is fatigued, stressed, or annoyed, they itch at 5 times higher? Yep, there you go. I mean, they are correlated in complicated ways. Obviously, the bile salts just didn't go up today. It's much more complicated than that.
And then touching for a minute on physical activity, we will talk about this more. Alagille patients may not want to be physically active. It may not be advisable for them to have certain types of physical activity, but I think we would all recognize that it is safe. It is important to have a level of appropriate physical activity, and we will discuss that. So, just to revisit some of these topics, and to go back to bones and breakages, I guess one question we have here is there any way for parents of very young children who haven't encountered fractures yet, is there any way for them to know if their child is more susceptible to that, and is there anything they should be doing to try and manage that aspect?
I think, the whole balance motoring question is actually really complicated. When I was very early in my career and there were no good vitamin E preparations, we would see what was called spinocerebellar degeneration from vitamin E deficiency. So it was necessary for nerve maturation, and the kids would have cerebellar disease, and so they would have poor balance because that's part of things that controls our sort of complicated movements. We've seen kids who have had bleeds in their cerebellum or in their brain where balance is an issue. There are clearly children who have angulation issues of the major bones of the legs. So they have a bow-legged sort of picture, even if they don't officially have rickets, they seem to have an abnormal run. So a lot of, 15-month-olds, 18-month-old kids, they run, and it's interesting to watch, but that same kind of barely balancing, swaying run at age 2 or age 3 is something that we see somewhat commonly in Alagille syndrome. I think that anyone with those issues is more likely to have a fall. And so I think there's some correlation there. The kids who are really cholestatic, where your vitamin D level, is always 8 or 10, the 25-hydroxy D level, they're clearly at issue. We do DEXA scans, bone density scans. How many people have had a bone density scan for their kid? Yeah, not as many. So a score of 0 is average and -1 is okay. And we see many children with Alagille syndrome where that score is -3 or -4, which means that out of 100 kids, that child for age is at the very, very bottom. And as Dr. Kennedy said, that measures the amount of calcium and phosphorus that's deposited in the bone. So their bones are really, they're like rubber, not concrete sort of things. I think all of those things add up together. And then there are just sometimes where the kids do things with other kids their age where there's a crash. And, if you collide with the kid who's on the 97th percentile and you're on the 3rd percentile, it's a Mack truck against a Volkswagen. You know who's going to sort of lose in that, It's interesting that's we don't see the animation of these slides until we're like here. This isn't the way we saw this. And I love the pictures, Cindy, but I don't love soccer for Alagille. So the people who have seen me, they know it makes me crazy to think that a 7, 9, 13-year-old kid is going to head a ball. And it's just, and you can't you could play, 3-year-old soccer. They don't even know where the ball is. But, once they get to that age and they want to spear that ball with their head, it's like the sport I like the least for Alagille syndrome. Just saying. I would much rather see that, I can't see from here, woman playing tennis than playing soccer. Just saying. Yeah. Trampolines, yeah.
So one of the topics that I either missed the slide or something, but it was oxygen deficiency. And Jeff, so can you talk a little bit about oxygen deficiency in Alagille syndrome? How often do children need to be on oxygen, and what are the things to look out for to know as a parent? Is that something you should be worried about or discussing with your physician?
So there are 2 big categories of why kids need oxygen. One is a problem with the lungs themselves, meaning the actual exchange of oxygen in the lung tissue isn't effective. And the other reason is that for some reason the oxygenated blood and deoxygenated blood are mixing, is in general the 2 big ways that you would look at this. There are certain forms of heart disease, and I think we'll talk about this probably in one of the other sessions, but one of the more common forms of heart disease beside the isolated stenosis that I had briefly mentioned before is something called tetralogy of Fallot. And in this particular problem, there are 2 variations on this in a big picture scenario. One of them, you can have trouble getting the blood to the lungs because there's a single sort of large obstruction, if you will, and the blood detours rather than going to the lungs. It detours and goes out the body. So some of the blue blood that hasn't quite gotten to the lungs yet ends up going to the body, and that may make that particular child blue. There's another sort of more complicated version of this where the lung blood vessels, the pulmonary arteries themselves, don't develop normally. And they actually develop in different pieces that are not directly attached to the heart. So in some of those patients, they're blue for a couple of different reasons. One, because the blood mixes together, and the second, in many of these patients, they also have narrowings or stenoses. The last group, which is the group that's probably the most common here, but quite frankly doesn't always need oxygen, is the group that just has the peripheral pulmonic stenosis. If that's the only problem that you have, in general you don't require oxygen. The heart does have to work harder than normal, and there are other associated issues with it, but that in and of itself doesn't actually require oxygen. Now, if you have that particular problem and a hole somewhere within the heart, such that as the pressures go up inside the heart, it then sends the blue blood or the deoxygenated blood over to the other side of the heart, then you may end up blue or cyanosed as well. So if the only problem is peripheral PS, peripheral pulmonary stenosis, you don't in general require oxygen. It's not uncommon for the kids with peripheral PS to have some other lesion inside the heart that may put them at risk for getting bluer. But probably the most common cardiac issue that ends up requiring oxygen, if not repaired, is the special version of tetralogy of Fallot. In general, most of the cardiac lesions can be repaired. Some of the more complicated ones, which was the ones where the pulmonary arteries don't form normally and they form in pieces, sometimes those are incredibly difficult to repair, and those are often the kids that end up on oxygen. So the questions that you want to end up asking are, why does my child need oxygen? Is there a repair for this so that they will be pink rather than blue? And is the reason for them requiring oxygen something what we call structural, meaning there are pieces missing or pieces that are narrowed, or is it a problem with their heart themselves and the blood shunting from one side to the other?
So Jeff, a lot of these problems you described, at least to me, sound like things that would be diagnosed pretty young in the infant's life. Is that a true statement, or are there cases where as the child gets older, an issue can become more acute?
So some of the, what I'll call bigger lesions, bigger diseases like tetralogy of Fallot, in general, those are diagnosed pretty early on, okay? Usually what happens is a pediatrician or somebody else hears a murmur, which is a fancy word for a noise when they listen. And one of the things that all the pediatricians do when they listen with their stethoscope is specifically they're listening for murmurs to see if there are issues there. Some of the more subtle lesions, for example, small holes in the heart, those may not actually be heard early on. We'll talk about more of these lesions later as well, but coarctation of the aorta, it depends on how severe it is. If it's severe, it may present as soon as they're born. If it's less severe, they may get noticed down the line, if you will. The one I think that most people here think about is peripheral pulmonic stenosis, though. And the interesting thing about peripheral PS is that it's a lot more easily missed than it should be. There are certain things that should trigger an evaluation, the first of which being the diagnosis of Alagille. And I can tell you for sure that we see patients all the time that are referred in for liver transplant, for example, or liver evaluation with known Alagille who've never seen a cardiologist, right? So the simple answer to your question is if you have the disease, you should be evaluated. The longer answer to that question is that while the peripheral pulmonic stenosis, for example, doesn't necessarily worsen over time, it's actually quite easily missed if it's not looked for. Somebody who's listening for it would probably hear it, but if you're not listening specifically for that, you may easily miss it.
Right, thank you. So, children will be children. They will fall and they will, want to run and jump. And I'm sure as a parent, you want your child to be as active and normal as any other child, and you can't wrap them up in bubble wrap. But we've heard from David that soccer is not his favorite thing for our children. But specific things that you would divert them towards, and then as a parent, how have you managed those conversations with your children about what they can and can't do, or how have you dealt with that in your experience?
Chloe has been begging me for years to do gymnastics. I'm scared to death of it. I don't want her to do it. We have a talk about it, but she physically knows already that she can't do it. And no matter how many times she asks me and we have a discussion, she already knows her limitations at 12 years old. She knows that she can't run. They do a mile run at school. She struggles with that. So I think a lot of the kids already know that they can't do some of these things, and they want to just get permission to do it. And then once you give them permission, it's settled, almost. It's a big struggle as a parent. There are many things that, they can't do. And even things such as going up and down the stairs quickly, or, carrying things up to their room, or whatever it might be. It's a gentle discussion that you have to have. Obviously, I know that many of you have had those, but also a thoughtful one in that let's find you something that you can do. I think we divert a lot of energy to art and projects and crafts and, bike riding and things that are less.
Like riding with a helmet, I assume.
Yes.
I could see it.
And knee pads and shoulder pads and
and a
No,
spleen
but-
guard if needed.
yes.
I think the way that I explain it to the Alagille kids, and quite frankly, I explain it to a lot of the cardiac kids, is I talk about lifelong heart healthy activities, right? And so if you think about the things that we all do and that we still like doing, they're the things likely that your kids can do, right?
Mhm.
So biking, swimming, walking, things of those nature are always golf, tennis. The things that you can still do when you get old are the things that are great for the kids, because quite frankly, they're not only lifelong activities, but they're actually heart healthy.
Right.
And so all of the aerobic activities we encourage. And so again, it's not just the Alagille kids. There are a ton of kids with other heart disease, but the lifelong heart healthy activities are the ones that we always encourage.
I think if they start playing golf now, how good they'll be when they're adults.
And adding running to that, of course, and all of those are also bone healthy. So maybe swimming slightly less, but those kind of exercises are also good for, accumulating bone. So, I agree totally that those are the right things to do. You don't want head impact. You don't want things where size really matters. And you want things where they can be successful. So you want to guide them into something where they can feel empowered and good about doing it. And for those things that are, irrational things for them to pick, you want to sort of guide them early away from it.
And another advice I give in the same line is, your kids are going to do what you do and what you like. And you, unfortunately, you have to put some sacrifice sometimes. You cannot be watching football all week long and expect your kid doesn't want to play football or doesn't want to play soccer. I think you have to, or what kind of things you like, and then you become part of his life. Then from early on, yes, it doesn't mean that you cannot watch any game, but I think balance out. If you know the kid will never be able to do something, I think that's one aspect that lead them to do it, is the fact that they see you doing it, or they watch you doing it, or watch you watching on TV.
That's a good point. We have a question?
I just wanted to, one thing that we did that Elena did as she got older. Of course, David would totally freak out that she did play soccer and she was the goalie, but it was indoor soccer, so at least which can be even worse. And she did ski, but it was with a helmet, and she did ice skate, but it was also with a helmet. She was the only one in her class that had a helmet on, but at least I made her wear a helmet when she was learning how to ice skate. But as she got older, I think there are adaptations that you can make as well. So like maybe she wouldn't run because she didn't have the stamina for that, but she had an LA Fitness membership and she did the elliptical. And you get the same kind of motion out of that as you would if you were running, but it wasn't the impact that you get of pounding on the pavement. Or a stationary bike. If you're worried about your child falling on their bicycle, you can do a stationary bike. So there are things like that that you can adapt as they get older as well.
Mm-hmm. maybe the advent of things like the Wii, where exercise becomes in front of the TV, is a good thing for kids with Alagille.
I have a question about the pulmonary stenosis. So my daughter does have some of that, and what we were kind of led to believe is that as she ages, that it will only continue to improve. But what I'm hearing is that maybe that's not necessarily the case, and we do need to continue to closely follow it. Can one of you maybe address that?
So in general, the relative obstruction doesn't usually change a lot. But in general, it also doesn't necessarily, quote unquote, improve. And we'll talk through all of this later, but there are a couple of different pieces of the actual narrowings that become important to follow. In the setting of the blockages, the pressure inside the heart, in general, will tend to be higher than normal. There are some kids who have mild or moderate degrees of narrowing, and their pressures are reasonably normal, and that's fine. But the other thing that we always look at is how much blood goes to each lung, right? So in general, it's 50-50. It's not exactly, but for the sake of argument, it's 50-50. And when the narrowings get significant enough, sometimes much more blood can go to one lung rather than the other. And so we like to pay attention to that, because often, quite frankly, we'll actually think about doing something in that scenario to try to even the blood flow, right? There is some evidence that would suggest that lungs that don't get enough blood flow, they don't grow as well. Okay, what that exact number is, quite frankly, we don't know. And if you ask 6 or 8 different cardiologists, you'll probably get 10 answers. But we do follow it, and we do follow what are called lung scans in order to look at the relative flow to each side. And as long as the flow is reasonable and the pressure is not too high within the heart, then yes, we don't do anything about it.
Any other questions before we move on to the last section? Joe?
Martial arts, you have a strong opinion on it?
For like a 4-year-old or for like for real?
Like for demonstration version versus like competitive.
Sparring.
So obviously most martial arts centers now are guided mostly by lawyers, and you do a lot of things without ever really having high impact. Now, some kids get the confidence that they can do and receive high impact because they are brown belt certified and fully trained. I think if you watch TV, a sport you would not want your kids to do, Alagille or not, but like, the mixed martial arts,
UFC?
UFC, yeah. I mean, a kick to the spleen, could just quite frankly be fatal. A kick to the head, or something that knocks somebody over where they hit the ground and they haven't broken their fall with their arms. Better to break your arms than to whack your head. So, when they're 4 and 5, I mean, there are very few kids who actually take martial arts to the point where they actually ever have an impact, So I think there's probably more danger in soccer, where everybody heads the ball, and they head somebody else's head, because they're both going for the ball and they both miss the ball, but they hit each other's heads. But it wouldn't be where I would guide somebody. But on the other hand, I have to say, of the different things, I've probably allowed more kids to do that because it gives you this sense of empowerment, and you're like the smaller 8-year-old, and so you're going to get your gown, whatever it is, and I'm okay with it when they're young. But it's also like T-ball is okay. By the time you get to like Little League, the pitchers are wild and crazy, and they're going to hit you. I even make a little bit of a difference between lefties and righties in baseball. I mean, a lefty, the spleen, is covered in the back, and a righty, the spleen is facing the pitcher. And, that's right where every kid gets hit with a ball. By the time you get to high school, it's a hard ball. It's going 60 miles an hour. I don't love that at all. So martial arts in a 4-year-old, yeah, it's cute.
We have another question at the back. This will be the last question. We'll have some questions at the end, time for questions at the end.
In reference to the head injuries, is the concern related to the predominant veins in their head, or is it due to the bone density that we're concerned about?
Yeah, so there's been a literature on both, but it really is more the bleeding. So is that bleeding because they are slightly less protected by the skull? So there have been some papers about thinness of the skull and the skull bone, but it's the combination of the things that we said that are bleeding tendencies, which could be the PT, the platelets, the integrity of the blood vessels, and maybe an unsuspected abnormality of the blood vessels. Plus, more and more kids and professional athletes get whacked in the head, and we just know that even if it's a concussion without a bleed, it's not good. And so I think in general, there needs to be more protection, against head injuries. And I think there are more and more even in like soccer. I love soccer as a sport, but that, maybe these younger kids with their plastic and developing brains shouldn't be, heading the ball all the time and trying to emulate professional athletes, Same like, pee-wee football, they shouldn't be spearing each other with their heads to tackle them, So it's a combination of things. But the number of children who have had a recognized or an unrecognized bleed into the brain is strikingly high in Alagille syndrome compared to other, pediatric liver diseases. And it's one of those things you can do to protect your child. I think you just got to do it.
Okay. So let's move on to the last topic and leave as much time at the end for questions as possible. So the last topic for this morning is head and brain. What are the challenges? So things like cold and flu and fever, how do we think about these in Alagilles? Headaches, migraines, brain fog or encephalopathy, dental concerns or discolored teeth, hearing problems, vision problems. These are all things that can affect children with Alagille syndrome. Cindy, you do like your animations. Sometimes it may be hard to know whether your child just has a cold or a flu or if it's something more serious. I think that's true for all children, but maybe more magnified in Alagille syndrome. And exactly what to do about it, how to treat, what's safe. We'll talk about that. Headaches.
So I'd say that just on the last slide, since it was the slide, cold, flu, fever, stuff like that, I think just like any other kid, common sense, pediatrician, there's not some extraordinary susceptibility unless you have something like a very significant heart lesion. Mm-hmm. That's a whole different story. If you've had a Kasai operation for your liver because you were diagnosed with biliary atresia, that's a whole different thing. But although Jagged and Notch are very involved in immune system signaling, it hasn't seemed to us that there's any significant difference in Alagille kids compared to other kids. There is a paper that is either coming out or has just come out from British group that suggests that there are some immunoregulatory abnormalities, but it's not really what we've seen. I don't know your experience.
No, I will agree. Not of clinical significance. There has been some issues in regard to with otitis media, that because some issues with the bone development, sometimes the Alagille kids are more prone to it. That I think just they need more prone attention from the ear specialists. But I think other than that, I completely agree with. I don't have too much to add to that.
Okay. Headaches.
So I think headaches always have to be investigated. A lot of people have headaches, but they have potentially more causes, more important ramifications in kids with Alagille syndrome. So, do you know, and I think we'll probably talk about later on today, there kind of like 3 different kinds of hypertension. But, some young kids with Alagille syndrome have really very high blood pressure, cuff kind of hypertension. They might have headaches. Someone could have pressure. There's been pressure in the brain seen in, and again, these are each individually rare but very important. Sometimes felt to be maybe due to vitamin A, sometimes other things that cause headaches, so pseudotumor, people who have had a recent bleed or a remote bleed, people who have poor blood vessel perfusion of their brain. So I think very definitely if you have an unusual pattern of headaches, you need to be seen and not by your gastroenterologist, by a neurologist. And more now there are special headache programs in, I think, most pediatric neurology divisions, and I would take that one very seriously.
I assume it goes without saying any headache after any sort of an impact is
For sure.
particularly.
Yeah.
Okay. Brain fog, encephalopathy. Who wants to take that one?
I guess there will be one in particular. I mean, other than the potential brain issues, if this is some of the fogginess or dizziness or any of the symptoms are in relation to headaches and things like that. As David just mentioned, I think neurologists should be involved. I think being dizzy could come from different organs in Alagille. Also, if there's a heart condition, if there's anything that is changing in your heart condition that needs to be looked at, that is affecting oxygenation or some changes like that can give you kind of a foggy brain. I think if it's in relation to the liver and having encephalopathy, I think that would be in a more advanced liver disease scenario. If you don't have cirrhosis or your child doesn't have cirrhosis, I find that it's very difficult to develop these things just from liver disease at itself. It may be a combination of other factors, but not necessarily in relation to that. But when you start seeing certain things like your kid cannot write well, or the school performance start kind of going down, and there has been some concern about the spleen getting larger or anything that may suggest a progression of the liver disease, I think so those things has to be looked at in depth by the PDGI. But again, you have to put in context that this is not a single organ disease. There are other issues that we have mentioned here throughout our conversation that you need to look at that can lead to you to be dizzy, to be foggy, to be tired. Yeah.
What about ammonia, breath, and just sort of the smell? The smell of the breath can change with the buildup of ammonia.
Well, it can happen, but I think by the time that I think more subtle will be like if there are changes in the liver that lead you to I mean, like kids that can write, they're still losing that ability to write well. They lose that ability to concentrate. In more advanced liver disease, you can have these halitosis or certain things that have been described that can lead you to concern about the liver disease. But I think, to be quite honest, majority of the time when kids has like bad breath or something like that, I usually find some other reasons for it. Like dental care is very important. I think that's something that unfortunately is overlooked at times. And more in Alagille syndrome, I think we really have to keep on top on that aspect. Gingival disease, also gingivitis due to dental care issues. That can be affected by the disease itself. Remember that sometimes these kids have severe cholestasis early on in their life, can lead to, decoloration of the teeth and things like that. And the transient teeth are important for the permanent teeth. And I think that's important also to keep in mind.
That's perfect. It was the next slide. What about teeth? So you got a 2 for 1 there. Thank you. So what about hearing and hearing loss?
Okay. I think it's something that need to be looked at. I think something that we have found in different studies is that, and as we mentioned at the beginning of at the beginning of this meeting yesterday, today, you know, how the vessels develop, what we call angiogenesis, the blood flow to different areas of the body. This is going to be affected by this genetic problem. I think more and more we believe that some of the issues are in relation to that, as we see in the heart, we see even the liver. There is some speculation could be the way your vessels develop and the blood flow to the bile ducts and so forth. In the same fashion, we have described problems with the temporal bone that is very crucial to keep inside the inside cavities. What is the middle ear and internal ear sometimes can be affected by this, the development of the temporal bone. And that's one of the things can lead to some of the things that were described initially, to more frequent otitis media or ear infections in the middle ear. That's something that obviously that can happen in any kid, even without allergies. But in kids with allergies, the speculation is that because of the temporal bone and the bones inside, they have some issues that happen during development, that they are more prone to it. In the same fashion, you can have hearing issues in relation to all this, as well as any other issues, nutritional issues as well. I mean, the hearing is something that has to be looked at in patients with Alagille. I will say that needs to be tested just to understand if there is any hearing problem. And sometimes medications that they are put early on can affect hearing as well.
Roberta, anything to add on fogginess, hearing issues that you've experienced?
Fogginess that we experience is more of a lack of concentration, lack of focus at school, homework, those kind of things. Are they directly correlated to the foggy brain? I would say probably not. More correlated to the itching.
Itching, sleep.
Yeah.
Okay. David, did you have a comment on hearing? Don't play soccer. It affects your hearing too.
If you get hit in the ear. No. For the last several symposia, the group, from UCLA was here to study hearing. And I think, again, something you can do something about. If you think that your child's articulation and enunciation is not impeccable, get it checked. Because, it's very hard to tell subtle learning things, in the classroom. You have to hear precisely and you have to be able to see precisely, and you just need to get those checked. And I think that they showed that. And I have to say, at the last one, I actually didn't become a cardiologist for two reasons. It was my love, and I ended up in GI secondarily. But one of them was because my mother had convinced me, because of my rock band years, that I would be high-tone deaf by the time I was 25. And this is unbeknownst to Cindy, but at the last symposium, the audiologist, who came with all of her equipment and everything else, and she was lovely, was unencumbered by patients. And so I said, listen, I've never had a hearing test, but I'm sure that I can't hear like treble. Can I come up and see how damaged I am? And I totally passed with flying colors. I have like perfect hearing despite standing in front of the speaker bank. And I went back to my mother and said, you fibbed to me. You fibbed to me. I could have been a cardiologist.
Well, I think the Alagille community is happy that your mom told that fib and you went into GI. So.
I'll let her know that.
So David, you just mentioned vision and the importance of vision in the classroom, and I think that there are some interesting aspects of eyes and vision in Alagille that you would love to tell us about.
Sure. So the number of eye abnormalities, sort of like the number of kidney abnormalities, is actually huge. And for the eye doctors, this is an autosomal dominant defect in anterior chamber development of the eye. And somebody asked last night, which manifestations go forward and which ones don't. So some of these things are congenital things that are striking, they mean nothing. Other ones are congenital abnormalities that matter. And then some of them are progressive. So for a long time, we had problems with pigmentary retinopathy, like retinitis pigmentosa, which is not a congenital part of Alagille syndrome, but it's a chronic sequelae of having vitamin deficiencies, which, you know, a long time ago was really a terrible thing. So when you go to an eye doctor, you can have corneal problems, you can have keratoconus, you can have embryotoxin, but they'll tell you it really doesn't matter, or maybe it gives you a little bit of a risk of narrow angle glaucoma. But you really want someone, you want an ophthalmologist to look, and if you're very cholestatic, you want to go back in a couple of years. But you want to bring one of the ophthalmologic papers with you and say, this is what I have, this is what my people get. Do I have these? You know, because they know how to do each of those things. They just wouldn't normally do them in a 5, 10, or 15-year-old.
Right. Excellent. And I think that's an important point. And, you know, it's true for me in the industry of drug development, when we go to talk to the FDA, you kind of think about the FDA as these people up on a hill who know everything. And the reality is they don't. You know, they're only human beings. They're physicians. They're trained, but they don't know the ins and outs of every disease. And a lot of the people in your care team may not know the ins and outs of this disease. And, you know, my personal approach is I want to make it easy for them to do their job. And my version of them doing their job is saying yes to what I want to do. So I give them the information. I bring it with me. And my job is a big part of my job is to help them understand and educate them. And I think that if you have an article or you want to get armed with the things that you need when you're going to your dentist or to your ophthalmologist, then I think the Alliance is here to really help you and empower you to do those things and go with some ammunition so you can get what you want. So before we open it up to questions, I did have one question. We kind of brushed over cold, flu, headache. In terms of patients with liver disease, what do we think about Tylenol or a lot of over-the-counter medications that parents might normally give to their children without thinking too much? And is that okay, or should we be thinking differently about that? Acetaminophen in particular.
Yeah, acetaminophen. We use the generic word. I think it's interesting with acetaminophen, the history of it, because we 20 years ago, 25 years ago, would say it doesn't cause any major problem. And then for about the last decade, we have been hearing all these misadventures and all these issues with acute liver failure, and the only thing we found was that there was a acetaminophen overdose, or you know, the other thing has been in the market, all these different medications that already had it added on, and you don't realize it's already there, and I think that brought us all the way to the other extreme where this is bad for the liver. The issue we're going to struggle with in a patient with Alagille is that if he has fever, how are you going to deal with it? If you hear the story about acetaminophen, and I can tell you the story about ibuprofen also, where you worry about the kidney, where you worry about the patient having low platelet count, and how the use of that can affect the function of the platelet count if it's overall more concerned if it's low, as we have mentioned through this morning. Then I believe that, and then you cannot just give comfort to your child if he has fever, because these two choices has something bad going on. I think you have to just use it carefully, use a low dose. Don't be guided. Usually with those, we have a range to dose it, 10 to 15 milligrams per kilo per dose. We usually go more with the 10. Pay attention to your child if he's eating or eating, fasting, affect the impact of acetaminophen to the liver, potential causing problems. You give it 3 times on that dose. Usually, most of the time will be safe. I think more important also is going to be if you are giving this, don't do it for a long period of time without having someone recognize what is happening to your child, why he's having fever or she's having fever. You have to feel that part. I think the ibuprofen is also okay overall if his the platelet count is fine. There's not a lot of concern about kidney disease. When we are talking about a X amount of doses over a short period of time. I think the more important thing is that none of this should be chronically used or used without really thinking about what we are doing, why we're we try to keep the child comfort, but we don't want to overdo. I think overdoing it and forgetting about all these other factors. Yeah.
So you mentioned it's important to know whether they've eaten or not eaten, which is preferred.
That they are eating. That you will run into more. I mean, well, there's the ibuprofen can cause gastritis. People talk about taking it with something in your stomach, rather than empty stomach. But I think that the times that I have seen sometimes is when kids has vomiting and diarrhea, and they keep on having vomiting and diarrhea. They cannot keep things down, and the only thing they are getting around the clock is acetaminophen, even though it's in the right dose. They get in trouble. They can get in trouble because of that. It tends to affect the way your liver metabolizes the acetaminophen when you are fasting, basically.
I think the one point that Dr. Quiros made, many people do sort of alternate a little bit of this and then that, and then maybe you get potential for the side effects of both, but you have a lower dose. But when you do ibuprofen, which, we try not to use brand names here, but then we're talking about, Motrin, Advil, naproxen, everything else in that family. If your kid is not eating and you give them that, it can be incredibly damaging to the stomach. And, it says take with food, but, people don't read the bottle. They just, and since it's over the counter, 2, 3, 4, that's probably, people go out and they play soccer and they come in and they take 4 of those, But, as pediatric gastroenterologists, we see 8 and 10-year-old kids who come in and they've bled half of their blood volume just because they took one of these medicines and it burned a hole in their stomach wall. So the stomach wall in many patients with Alagille syndrome is under pressure. It's under portal hypertensive pressure. And so those meds, are not at all without toxicity in anybody, but certainly you want to take them with food or don't be taking that. And I think I agree, 1 day's worth of these meds taken with food is okay. Some of the bigger problems, we've started to recognize in adults that if you drink very heavily and then decide to do your hangover with a lot of Tylenol before you go to bed, you actually can kill liver cells that way. And that was something that wasn't really recognized for a long time. Tylenol, acetaminophen, every other, So they are things that you do, as Dr. Quiros said, you want to make your child comfortable. You want to be reasonable. Don't overdose. Don't think that the adult pills are okay for your 4-year-old, because they're not, by the second day, start to think about what's the source of the fever and should we be doing something else.
Roberta?
So with many of our kids, we have 6, 7, 8, 9, 10 meds in the morning, 10 meds at night. And for me, when I give Chloe something like that, I'm always concerned, will these interfere with any of the regular meds, the rifampin, the Ursodol, bicarbs, anything that we might be taking like that. So obviously we're going to talk to our doctors about these things, but, as a general rule of thumb, can we take things like Tylenol and ibuprofen around the same times as all of our other meds? Or do we need to space them out because we're giving so many meds? And as parents, and we're talking to our doctors about these things, we forget what med is with what med, and what's your opinion on that?
So I think a lot of us have different opinions about this, and I'm probably on one end of the spectrum. There are a small number of meds where it really, really, really does matter if they're taken close to other meds or if they're taken on an empty stomach. And there are some meds where it really does matter where they're taken with something in your stomach, and then most of the others, it really doesn't matter. So you don't want to give Questran and Urso together. You don't want to give Questran and vitamin D together. You don't want to take ibuprofen on an empty stomach. And on a bad day, it doesn't really make a big difference if you hold back on, you know, the vitamin D or the, you know, they're just sometimes when you just can't, particularly if you don't have a tube, get it all in. But I think those are the major things. But, you know, it's like, for me, the acid blockers. If your child has reflux, you know, you have to get your kid up early on an empty stomach. You know, it honestly doesn't make that much of a difference. You know, and ultimately, you can do all of those very precise, every 90 minutes you're giving another medicine thing. And you could be doing your vitamin D totally correctly that way. But if you don't have a blood level that's adequate, it doesn't matter that you're doing that. And if you give it with or other things, if your blood level's adequate, it exonerates it. So I did have one patient who, despite having a G-tube and a cholesterol of 1,800, the dad mixed all the medicines together and blasted them into the G-tube 3 times a day. She always had great levels. He did something to one of the medicines that I can't even say on mic, but he said it allowed him to blast it through the G-tube because she wouldn't take it orally. But it worked out. And, you know, so the proof of the pudding is in the vitamin D level.
I just want to add to what David said is, you know, I agree. I mean, I'm also on the end of the spectrum. I think you cannot really prove that there's a major issue when you give them together. I will give it together. I think when you deal with someone that is taking 10 medications in a day, it becomes very hectic if you start developing all this by the book way of delivering, before meals, after meals, 1 hour before meal, 1 hour before or after that medication. You cannot do anything. The cholesterol drive a lot of people crazy when you are doing like 3 times a day. That's taking 6 hours out of the day. I mean, you start adding up all these things. I think you have to be practical about it. And one thing I do with patients that take more than one medication, take several medications, like I deal with transplant also, and Alagille and all these different diseases, is I really develop this high priority med list. Like in a crisis, these are the 1 or 2 or 3 medications that you really have to take. You have to figure it out. That's your priority during an acute illness. Because the vitamin D, I mean, things that David was saying, there are certain medications that, yes, it's important, there's a reason for it, but missing 2, 3, 4 days even sometimes in a bad situation is not as critical as this other medication. Then having a little bit of priority, knowing that this is medication, the number 1, 2, and 3 that I need to give throughout the day when having a bad day, these are the ones I have to focus on.
Okay, so we are officially slightly over time, but that's okay. So we don't really have time for any more questions from the audience, but if you have questions, please approach the panel and ask them. I think that's why we're all here. When I say we, I mean that's kind of a royal we that's pushed that way. But we do have some feedback forms that are really important in helping us understand if we're delivering the kinds of topics and discussions that you want. Just a show of hands. Has anybody feel like they've learned something about Alagille syndrome that's going to help them? Okay, mission accomplished. Excellent. So we appreciate your honest feedback, any ideas you have about other topics you'd like to hear. And you'll be seeing these feedback forms throughout the conference. We do really pay attention to them. And feel free to write anything that you want to hear about in that open section. I would like to thank our panels for their tremendous input and discussion, and onwards and upwards. I think we'll all be writing surfboards of information into the waves of Alagille syndrome before the weekend's over. Thank you.